Office of the Assistant Secretary for Preparedness and Response under the Federal Department of Health and Human Services. And my job is the Federal Project Officer for the HPP grants here in California, in LA, and in some other jurisdictions in Region 9. And what we're here to talk to you about today is the Coalition Surge Test. It's an exercise that we at HPP put together. When I say HPP, I collectively mean the HPP program in Washington, D.C., and the regional offices, the 10 regional offices throughout the country, in collaboration with a company called RAND Corporation out of Santa Monica. So we looked at some different ways to look how we could engage coalitions to work together, and that's what we're going to be talking about today. Has anybody here had a chance to download and walk through and read anything about this test, this exercise tool yet? If you have, just kind of give me a show of hands, and it's okay if you haven't. I understand. Wasn't any homework or anything like that. We'll walk through. There's no quiz, right, Phil? No quiz on it. Okay, so we're good to go. So this is what we're going to do today. Give me an overview of this, how we came to have this tool, why we decided on this type of exercise, why we use an evacuation scenario, and we're going to do some hands-on demo. We're going to go through the actual Microsoft Excel tools. We're going to make sure you leave here understanding really, what this is and how really hopefully simple it is for you to take back and engage your coalitions and your other folks with this thing. There's some performance measures that impact every healthcare coalition here today. So you'll be reporting on those performance measures back up to Barbara Taylor from CDPH is here, and to her staff. So I want to say welcome to her and her folks. And so I'm not sure exactly how that goes, but the program managers, your contract managers are here. I'm sure they'll be able to talk to you about how that's going to happen at the end of the year. And then again, questions and answers. But I want to say, if this is very informal, if you have, call me Kevin and say, Kevin, I don't know, what do you go back, or what do you think of this, or why did you do that? So if you have questions that you go through, other people are here to have questions. So we're here to inform you, but it should be a very interactive dialogue. So feel free to just jump in, and we'll move along. So let's just go over, like I said. The first thing we do is we're going to talk about the exercise, that it is an annual requirement for every funded healthcare coalition within the HPP program to exercise with this tool in this year, at least in this year. Our plan is to have it all of the next 5 years, but right now we guarantee that this will be a requirement in this year. It's a low to no notice hospital evacuation scenario. And the reason we did this is we've had a number of hospitals in the country who've had to evacuate. Either wildfire is one. We've had a hospital who had a flood. They had a real large rainstorm one night. They got about a foot of rain, and it was a 500-bed hospital in Houston. They had to evacuate. Obviously, hospitals down in Joplin, Missouri for tornadoes, remember those, they had to evacuate. We had some down in Southern California. Hospital had to evacuate due to an earthquake a few years ago in Peril County. So we've had this come up. But one thing we've noticed about hospitals that have had to evacuate, we've even had hospitals who have had planned evacuations, meaning we're building a new facility here and we're moving all the patients on this date from here to here, and even the coordination of that is it takes a number of people to make that happen successfully. So that was why we came up with this scenario. We thought it was a scenario that is real world. It does affect hospitals. Two, you can't do it necessarily on your own as a hospital. Hopefully you can have your partners in the healthcare coalition help you do this. And then it also involves emergency management. EMS agencies have to participate. Emergency management should be potentially participating. You're receiving hospitals, the hospitals that maybe you compete with on a daily basis. They may have to come and help you and give you some idea about what their bed availability is and what patients they can take in. But this is kind of the reason we put this together. When we initially put this test or exercise or tool, we called it We call it the Coalition Surge Test, the CST. It was not intended to be something that we would use for every coalition in the country. We put it together just as if a coalition were looking for something that they could use, an exercise that you guys wouldn't have to spend a lot of time and effort to put together. You could take it and you could go, and but it kind of evolved to being something where for the first time ever in the HPP program, all coalitions in the country are going to be using the same scenario, using these same tools. And it'd be our job to report back to the nation, really, what did we learn from all the hours that we've spent putting this together? How did we move this preparedness dial forward? What went right with the tool? What do we need to change, about it? We anticipate there will be a lot of great ideas about, hey, what if we did this, or what do you think about that? There's things that we will definitely look at over the next year as we come through. Let's see, there's going to be, as I said, there's 2 Microsoft Excel. If you use a Microsoft Excel spreadsheet anytime in your life, it'll be easy. It's easy to work through this. And there's 2 phases. Phase 1 is a tabletop exercise with a facilitated discussion. Phase 2 is an after-action review. And then there's 8 performance measures linked to the execution of this. So that's an overview of the test. So what's the role of the healthcare coalitions? What are we really ultimately trying to get to? And I get questions like, well, this is a 90-minute exercise. We don't think we're going to be able to place all our patients in the coalition in 90 minutes, from this hospital. So the intent is that you would have your larger hospitals evacuating to your smaller hospitals. But the intent is not to beat the test. It's not to say, oh, we placed everybody in 90 minutes, we're good to go. That's not it, because everyone in here works in healthcare, and you know that your ability to place patients can change on a day-to-day basis depending on the census that you have and the demands or any type of other emergencies that are going on at the same time. But the intent is really to for collaboration and coordination amongst these people, the people here in the room. California is unique in that you have this kind of built-in Mohawk RDMHS system. You know your RDMHS is, you know your Mohawk, you know CDPH and EMSA, you work with those folks. You have kind of a ready-made system. You all have kind of sing to the same sheet of music. You all know how to put your own, if you have resource requests, you guys know the pathway, the forms, all that works together. And that's phenomenal. And this system is to work within that current system that you have here in California, not to supplant it or anything like that. It's to work exactly within the systems that you have. So in some areas of the country, that doesn't exist. In some areas of the country, a receiving hospital or evacuating hospital says, hey, we're just going to call the other hospitals around us and try to do this on our own. Hopefully, they don't have this built-in system that you guys in California you guys have put together. So let's see. Here's our roles: collaborate and coordinate. You want to work with your EMS folks to ensure you're going to have some medical transportation, appropriate medical transportation, and then you're going to identify essential elements of information that inform other healthcare coalition members. Maybe some of your healthcare coalition members, let's say dialysis, won't be necessarily a part of this exercise. But I've had some dialysis folks sit in on some of these pilot tests that we've done, and they're like, I learned a ton because I had no idea that this is how the system works. If we have problems, we know who to contact better, we know who our partners are. So something to consider as we move forward. So let's talk about this scenario. This scenario is you're going to determine why your hospital has to evacuate. Whatever that reason is, you determine. We played around coming up with a scenario too, and it just didn't work. We just said, well, we'll let you guys figure out what that is. So in the middle, let's see, on the left you have the evacuating hospital, on the right you have receiving hospitals, and this could be long-term care facilities as well. Okay, so we just want, we're a mix of hospitals and long-term care facilities. But for simplicity, we just put this in here. Then the orange arrows really are just information. There's no actual movement of patients in this exercise. So in the middle part, this slide is set up generically for the entire country, not really for California. So the middle part, you have your Mohawks, your RDMHS, you have all that working together in the middle. We called it the Regional Healthcare Coordination Center, where you would have your EFA component, your emergency management, EMS component come together. Is it in a physical room? In some cases, yes. Is it virtually? In some places, yes. Completely virtually in a lot of places. So whatever that coordinating entity is, that's what we're hoping to see. That doesn't, like I said, that middle part doesn't exist in some locations. Sometimes the evacuating hospital is only calling the county emergency manager and saying, hey, we got a problem, can you help us? And that's how that system worked. If it was New Jersey, that's kind of how they told me that's how their system would work there. So, but theoretically, we want to get the healthcare coalition engaged in this exercise as much as we can. We say if your healthcare coalition has no role in the response at all, or we're not trying to nationally change anybody's model, but we like to see better coordination within healthcare coalitions if possible. So that's the scenario. The real only inject is that the evacuating hospital gets a call from someone in this room. So I'm going to, and I was talking to Phil and Shelley, I'm going to kind of, I would say, focus this presentation on the fact that you're going to be a trusted insider or a peer assessor. You're going to be putting this exercise on for your coalition. So you would call up the evacuating hospital and say, hey, today's the day, you've been tapped, we're going to evacuate. And that's the only real inject into the exercise. So we have two MS Excel spreadsheets. We have evacuating tool we're going to go into, and a LEAD tool, which is the Regional Healthcare Coordination Center tool. We have a Trusted Insider handbook, and it's easy to search. Does anybody have do you have internet capability in the room? Okay, so if you go to so this is, as I said, just Google HCC search test, and this is our homepage on phe.gov. Public Health, which is publichealthemergency.gov, so phe.gov. If you haven't been there, I encourage you to go take a look at that site. But if you're looking for information about the test, we have a good one-page overview. Feel free to copy it, share it with your leaders, share it with your healthcare coalition members, share it with other members of your organization who are like, what are you talking about? What is this thing? And it's a good overview of the test. We have some information over here. Back in February, we did a national webinar on this. We had 3 of our 4 pilot healthcare coalitions, one from South Dakota, one from Michigan, and one from Texas, present on their findings, their thoughts, how they went about it. We have Lloyd Upton from the Houston Area Healthcare Coalition and talking about their participation in it there. So the first thing, and then we have some of the tools down here. So the first thing to click on here, and the first thing I would ask you guys to read, it's 16 pages, and it's a manual, and it just goes through, walks you through the tests, it gives you some ideas about how to put this together. If you see over here, it says things to do before the exercise, during the exercise, and after the exercise. Gives you a couple checklists at the end to help walk you through what you do if you're the trusted insider or the sample notification for coalition partners. So if you're going back and you're looking at this and you want to start getting ready, I would just make this first. The first thing to do is to read this handbook. You can share this handbook with all members of the exercise. It's not it's not secret. I think it's a good idea to keep everybody informed of what really is happening. But that's it. It's pretty straightforward, and but as I've joked about this before, we were predominantly men who put this thing together, and we said, well, we know a lot of us aren't going to read all the instructions and all the details, just going to pull it out of the box and put it together and see what happens. And so what we did was we put and this is now one of the spreadsheets. I just wanted to show you this. So we kind of went to the spreadsheet and we started with, oh, how do I use this tool? And give an overview. So even if you don't get to read the thing, and I encourage you to, you can begin going right into the Excel tools and it'll walk you through how that all comes together. Go back to the. So also here, under there, you have a zip file. And the zip file, and you have these two documents here. You're going to have something called the. I changed this because to put this demo together, but they all end in either an evac tool or lead tool with a date. So in there you'll see the latest versions of them on the website. So first we're going to open up the evac tool, and I'm going to go back here. I'm going to show you. I can go back. The evac tool will be used at the evacuating hospital. Kind of tie the two together. Remember, it's kind of mid putting this thing together, so we had to keep it as simple as we could. So the evac tool will be used there, and then we had something called the lead tool, like the lead assessor, we called it. The lead assessor would, we didn't necessarily call it the Healthcare Coalition we just called it the lead tool because wherever that coordination is going to take place, that's where we want that lead assessor to be. And that lead assessor will also facilitate the facilitated discussion. So that's where the two tools will be used. The evac tool will be used at the evacuating hospital or hospitals, and then there should be only one kind of regional healthcare coordination center. Okay, so let's get into the actual Excel tool. This is the evacuation tool. We're going to go over that first, and then we'll spend some time. So Phil said I have about 45 minutes to go over this, and then some time for questions. But again, if you have questions, by all means, let us know. So I'm going to go over this in a way that I'm kind of teaching you. I assume you guys will all have this in your hand at some future date. So that's where I'm going. I'm not really doing more of a general overview, kind of getting a little more into the weeds on this. And so if you can see across the top, we're in the Excel spreadsheet. We're in the first tab, the overview tab. As you see, there's all the tabs down here that we're going to go through. And so I just want to make sure you guys knew where I was. So you can see along the top, kind of walk you through this from the preparation phase to the phase 1 phase to the after action review phase. So if we give this tool, this evac tool, you're someone who's an evacuating hospital assessor, a peer assessor. So it gives you some instructions. It says, anything in gray, we want you to type information in. Because ultimately we're saving these Excel tools after. We're going to build through these tools, and then we're going to save them. You can use them in your after-action reports. I'm not sure exactly how CDPH wants you to share their information up to them, but you can use and save them afterwards. So you want to type in information as it goes through. If you prefer a paper person, you can just click here, and the Adobe Acrobat version of this tool will come up. So it's a PDF version, and it gives you everything there. You don't have to use a laptop or an Excel. You can use a paper version if you like, and you can go in and do this. Again, here's the overview. We talked about it. Again, no movement of actual patients. Evacuating facilities, we collectively representing 20% of your acute care bed capacity. That's the target number of bed or patients we'd like to see evacuated, approximately 20% within your healthcare coalition. And we recognize people like, well, we'll never be able to find beds within our healthcare coalition for 20%. Some have said, and that's okay. That's, again, it's something for you to consider. We had one of our pilot tests, we had Sioux Falls, South Dakota. They had 2 large 500-bed hospitals, right around 500 bed, and several other smaller hospitals. And that, during the exercise, one of the 500-bed hospitals said, well, okay, here's our patients, and the other 500-bed hospital, they work good together. They're really good friends, emergency managers. They said, we could take 4 of your NICU patients, and that was it on that day. So he's like, wait a minute, we went from, he goes, this whole, if I have to evacuate, I have to ask everybody in the state. In South Dakota, you know, to go outside of Sioux Falls is a 4 or 5 hour drive. So it just compounds the issues with EMS. And so it was something that they're now working on different plans, looking at ways that they can do that more effectively if they do have it, at least understand their gaps a little bit better than they did before when they did an exercise. So again, this is the first page, the overview page. It's an overview. Peer assessors administer and evaluate the exercise. That's what you guys would be. We talk through what they are. A trusted insider serves as a liaison between the coalition and this assessment team, which when I say the assessment team, I include these peer assessors that you're going to get. And again, the 2 phases I mentioned, the phase 1 is a tabletop exercise with a facilitated discussion. We call it a tabletop exercise with some functional elements because the evacuating hospital will likely, they either have like some type of their hospital evacuation plan, or they're going to activate their EOC. They're going to activate some plans. And then receiving hospitals, they don't necessarily have to activate like surge or anything like surge plans or anything like that, but they can. So there are some functional elements to this exercise, but ultimately it's a tabletop exercise. It's a coordination, communication, collaboration exercise. So phase 1 is going to be that initial 90 minutes of, hey, you have to evacuate, and the evacuating hospital says, who do I contact? What do I do? You guys have a process here in California, and maybe working within your coalition would this exercise would just help make sure you have the right numbers for everybody, know who to contact, how to keep people informed within your facility, those types of things. And then after, the other part of phase 1 is then a facilitated discussion. It's about 90 minutes of actual exercise play, about 90 minutes of facilitated discussion. That's kind of a recommendation we have. No movement of patients. And then phase 2 is what we call an after-action review. It can be up to 30 minutes. It can be longer if you like, but we would like for you to engage your healthcare executives, emergency management executives, public health EMS executives. We like decision makers, people who can understand and make decisions that if you have gaps that need resources applied to them, that you're going to discuss in this after-action review, that those decision makers are at the table. They don't necessarily have to be the CEO. They people who can, emergency managers, chief nursing officer, medical director, people who can make some decisions and make some things happen if need to be on either the receiving or evacuating facility. So each of the tabs down here has just a quick description of what it does, what's in the worksheet, and what do I do with this. So that's the overview tab. Second tab is the preparation tab. And this is where you're the lead assessor. It gives you just some guidelines. This is what you should be thinking about a month before. Schedule a meeting or teleconference with the entire assessment team. 2 weeks before, ensure that you and fellow evac assessors have the appropriate tool and training materials. And at least 1 week before, input the scheduled date and time for the exercise will be provided by the trusted insider. So we talk about a low notice, no notice exercise. And the reason we do this, and everybody here has been in exercises, and we just believe that it just gives you just a different view on your preparedness status within your facility from a low no notice exercise. I've been in some exercises where everybody knew everything about it. Scenario, the date, the time, everybody, the A team was there, everybody, everything was good, everything was green, everybody thumbs up, and okay, did we really, we did something, it helped us, but maybe there's some other areas we could look at in a no-notice environment, because many of these scenarios will be no-notice environment when you have to evacuate your hospital. So that's why we encourage this low notice or no notice status. We can talk maybe more about that or some ideas you guys have within your coalitions after. Or if anybody, again, if you have any questions, we can go through this. Again, if it's a gray box, what do you do in a gray box? Type something in. Okay, so here's your date and your start time. Here's where you want to start. We could put in your healthcare coalition. You should have an idea, obviously you guys would, of the number of acute care beds in your coalition. And then here's some information on your evacuating facilities. So ideally you should have all the potential hospitals here. You as the exercise team identify which hospitals we want to evacuate. Which hospitals. Now, we'd like to encourage you to rotate this. Not every year the same hospital has, not Tracy doesn't be the one has to evacuate every year. You guys shouldn't have to be that one. Some years you should play a role of a receiving hospital as well. So identify your hospitals that you want to evacuate, and then make sure you have your contact information there, because on game day, maybe you're going to call Tracy. They're going to be our hospital, and then hey, we just can't do it. We just had some type of mass casualty incident. We're extremely busy. We're overwhelmed. Whatever. We're not ready to play today. Unfortunate, but this is the real world in what we live in. And so you have a couple of facilities here that you can contact and get to. Let's say that you do your best. You get all your facilities, and you only have 18%. Go with it. Just do the best you can with what. With what you have to work with. This is a real world. We give you some targets we'd like you to meet. We want you to get there. But then again, we also know we all work in healthcare. We know there's going to be some challenges and some things that aren't going to work out. So don't knock yourself up too much over these types of things. They're going to happen. And so let's see. A few days prior, here's another document. This is part of the within the tool itself. This is a Word document. This is for the evacuating hospital to use to start documenting their needs in terms of their evacuating facility needs. We track 7 different bed types: long-term care, general med-surg, ICU, peds, NICU, psychiatry, and labor and delivery. So this is a document, a Word document that you would print off and hand to the evacuating facility when you walked in. If the evacuating facility has an electronic means to track their patients in terms of an evacuation scenario that they like to use better, that's fine, that's great. Just make sure you get a copy of it when you're done. But if they don't have such a system, this is a document that they can use. So that gives them kind of the number of census that they would have, any patients that they're going to discharge, and then really the number of remaining patients they're going to have to find a receiving hospital location for. The second page of this is the beds that are confirmed at the receiving hospitals. For example, you put the name of the receiving hospital in there, whether the RDMHS, the Mohawk program, anybody, the Medical and Health Coordination Center, whomever helped you find these and connect the receiving hospital bed and evacuating hospital need, that's where you want to do. And then you just kind of start putting your number in here, how many they could take. So that's just a very important part of the program and part of the test, and just to hopefully you could, this will not be a challenge for anybody to put together. We've had I would say maybe probably half use this tool and half use like that, a WebEOC platform that they use, and everybody saw it and it says, yeah, this is what we would use in an evacuation scenario, and that's what everyone worked on. They're able to share that with some other receiving hospitals. It worked really well. And then the third page of this is just your vehicles recruited for patient transport. The name of a transport organization, ALS, BLS, number of total, any vans or buses or other. So that's just one of the documents that you would hand to the evacuating hospital. So that's the end of any questions on this preparation tab? Okay. Now this is initiating exercise. When you had defined who the evacuating facility is, obviously we type that name in there, and you as the lead, the evacuating assessor, you would physically go to that evacuating hospital. How we recommend to do that is that your trusted insider would call the evacuating hospital up and says, hey, you've been tapped, can you play today? Yes, we're ready to go. Fine. Wait till our assessor gets there before you start, however long that takes to get there. And hopefully that it's not too long. There's been some questions like, wait a minute, some of our facilities are really spread out and some of your facilities are pretty spread out. And so it might necessarily be a challenge to get that person there, especially if that person can't play. There's going to be some things I'm interested in. I don't have all the answers of how you work out some of those logistics, but that has been that brought up. I think, if I say, oh, I need 2 assessors, wait a minute, I got 4 hospitals, they're all 2 hours apart. How do I? So maybe a 2-hour start before the other facility is ready to go. But you don't want them to start until your assessor gets there. We put scripts in here, and we found that the scripts help answer a lot of information. You can add, these things you can always modify these Excel spreadsheets. You can add, like I said here, it says you may add more detailed scenario information if desired. We don't have, like I said, we don't define the specific reason why a facility has to evacuate. You may have it. We just had one of your healthcare coalitions in the Bay Area, they decided wildfire was the reason we're going to evacuate this hospital, and that was the scenario that they used. So. But we like you, in the blue, we'd like for you to read these scripts. And I encourage you to start, if you start this in 90 minutes, it'll pop up and say exercise is over. So if you get tied up and you're not sure, it'll remind you to stop the exercise. And then it gives you some instructions on ending the exercise. Then also we have a couple of questions here, that we think people will ask, that you're prepared to answer if that does come up. Okay, any questions on the initiation tab? All right. Now, one of the real reasons we want to have a peer assessor into the evacuating hospital. Let's talk about really what a peer assessor, our recommendation is on a peer assessor. Not necessarily somebody who works for that facility. We want somebody who is, a good professional, someone who is professional, who can come into another facility, but can look at it a little objectively. Say, oh, this area you did here, and what did you mean on this side? Not necessarily say everything worked great, but to give them some recommendations about things that might be able to improve upon. The other thing is that if you use a person from another facility, when you do this exercise again, that evacuating facility can be a peer assessor for someone else. And then you can, after a period of couple of years, you get a number of people looking at it from different perspectives, looking at different facilities, being able to share information, and really kind of being able to improve your whole healthcare coalition, really from one exercise to another, because you're getting different people involved, and they're looking at things differently, and they're able to share information amongst each other. But one of the things we'd like to have the peer assessor do, because we're going to talk about these things in a facilitated discussion, is to have some qualitative questions in an overview. Like, for example, we have some areas here that we would like for them to look at. Situational awareness, communication, transportation, patient tracking and information exchange, appropriate placement of patients, and regional healthcare coordination centers, if any. So under situational awareness, was able to get answers to its queries from receiving facilities in a timely manner. So if you agree, neutral, disagree, you can just check a box here, and then you can write your comments in over here, what you're observing, and save this later for your facilitated discussion, or for your after-action review and your after-action AARs that are due as well. If you want to make a change, you can click out of there. So that's what the intent of our qualitative portion of this exercise observation tab is about. If there's areas that you want to add, questions that you want to see, did they activate, whatever the regional healthcare coalition, did they use the regional healthcare coalition communication plan? If that was something that you have, or you have something specific like that, by all means, you can put that in there, and you can evaluate things internally that you want, if you want to do that within this exercise. So that'll be the exercise observation that will go for 90 minutes. You'll get that reminder, or somehow you'll know when 90 minutes is up. You just tell them that's the end of the exercise. You can move into the facilitated discussion. A couple strategies to have the facilitated discussion. If hospitals are fairly close and people can get together, that's ideal. But if not, obviously you can have a conference call. You have these folks from the receiving hospitals and the evacuating hospitals, as well as the EMS folks come into play. We'll talk more about EMS role in a second. So here, your job as the evacuating assessor is to type notes within the facilitated discussion, or bring up questions or observations or things that you observe that you can talk about here. Obviously, you want to save all this for later review as well. And this is, again, same. It looks exactly the same. This is the after action review. This is phase 2 of the exercise. This will happen no later than 30 days after the exercise. We wanted you to be able to go 30 days to get people's calendars, get on people's calendars, especially some of your executives' calendars, to make sure that they could participate in the after action review. Again, there's just here as your job in the after review, just be able to share information from your observations there at the evacuating facility. So that's the evacuate. That's one of the tools down. Any questions at all on before we move on to the lead tool? Any questions on the evacuating tool? Yeah, Sean.
I wanted to point out, a couple people have asked me, we will be using e-resource, and we'll talk about that after we have installed that. So,
Okay, no, great. All right. Next tool, the next Excel spreadsheet is the lead tool. This one's a little bit different. This one's different. It takes a little bit more. We get you a little busier with this person is. They have the first tab is the same, an overview, just really gives you an overview of the exercise and an overview of this tool. Again, you can click on the Adobe Acrobat version to have the paper. If you just want paper to deal with instead of you bring a laptop in, you can do that. So in the preparation phase, you're going to hit the RHCC location and the RHCC point of contact, whomever that is for your healthcare coalition, wherever that location is. If it's virtual, right, virtual. If it's a physical address at the public health office, and that's what you can put that in there as well. Again, your coalition. And then this is the number of number of acute care beds, have your facilities, and your point of contacts. This is very similar from the other spreadsheet. And these are all the organizations. Step 6 is you want to get a list, and you're probably sure you have all your contact information of everybody in your healthcare coalition, so maybe you guys are you don't need to do this, but just a point of contact that you'll have, because once the exercise initiates, for those who aren't playing, I would encourage the trusted insider to send an email out to everybody in the coalition saying, hey, this exercise is ongoing. We anticipate a facilitated discussion to happen in 2 hours. Here's the call-in information if you're playing or if you're not playing. So it won't be up to the trusted insider to call the receiving hospitals. It's however the process will work. The evacuating hospital knows they have to evacuate, and then however they go about contacting and making that happen is how that should happen. So again, so that's the preparation tab. The next tab is initiating the exercise. Here you would put in your actual evacuating facility's name and the assessor's name, start time. If you have more than one evacuating facilities, our current tool only allows you to expand up to 3 evacuating facilities. We're doing some modifications to be able to expand it up to more, but programmatically, if you're going to do more than 3 hospitals, you need another peer assessor for the evacuation. As you'll see as we go through, there's a lot for one person to capture within a 90-minute time frame. So that's something we want to. We'll be a little more clear on as when I say we, HPP nationally, be a little more clear on as we go through. So here's some talking points that you can walk through with the RHCC staff, and then some frequently asked questions as well. So the exercise, any questions on the initiation tab? Okay, all pretty straightforward so far. Here's, again, you see this is the qualitative overview, and this is one of the reasons that I think the more evacuating facilities you have, the more complex it gets and the more assessors that you're going to need. You're going to have to think through that a little bit, how that best will work. But there's a number of qualitative questions here, very similar to the evacuating tool. So here's what gets a little bit more complex. This is the most complex it gets, and this really isn't all that complex. So if you were to type in your evacuating facility here, you type in the name of the hospital, and then here's where we start tracking numbers that are going to show up at the end and use for your performance measures and your use for facilitate discussion. So remember, anything in gray you type in. So we ask you a question: what was your patient census at the start of this exercise? And that's something you're going to walk through during the facilitate discussion. The evacuating hospital is going to come to the facilitate discussion, and they're going to be able to answer these questions during that portion of the facilitated discussion. They're going to know their patient census at the start, how many patients they're able to discharge, how long did it take to complete your patient count and report that to the Healthcare Coalition, and then start the exercise, how long did it take to receive confirmation that appropriate beds were found for all your evacuating patients. I mean, this last question of how long did it take to receive confirmation that appropriate beds were found for all your evacuating patients, it may take you might not get there in 90 minutes. We fully understand that. So this is where you would also start documenting the receiving facilities and how many they took from long-term care or general med surgery, and this is where we start populating this information as part of the facilitated discussion. If you needed to add additional beds, you could click here, and additional evacuating hospitals, you could click there, and then more would come up. So that's really about as complex as it's getting. It doesn't really seem all that complex, does it, at the moment? Pretty simple, pretty much put in there, and just move it forward. So facilitate discussion on transportation. We're going to ask some obviously questions. Hopefully, this is why this slide I had up there having that regional healthcare coordination center have EMS involved, because you're going to need appropriate medical transportation. You're going to need somebody there to help facilitate that during this exercise. So from the start of the exercise, how long did it take to identify available and appropriate modes of transportation? So you just type in the amount of time. Then you can put down in this tab, in this table, the name of the transportation organization, number of ALS or BLS, other vehicles that are provided, and a number of patients matched to transport. So that's as complex as this spreadsheet will get. If you're more evacuating facilities, again, you could click that button and it could expand, and we could have more tables would come up. Any question on either the bed tab or the transportation tab? Because getting information there is important, because when we come up to our after action reviews, these tables will all be populated, and you can use obviously for the part of the facilitated discussion too, and it'll tell you in terms of how many beds you found or how many beds are remaining as we go through this, and it'll graph this out for you as you go through. So I suggest you take it, do some scenarios within your coalition. Just we take you a few minutes and go, hey, if we evacuated these two facilities, we likely would have these number of patients you have to evacuate. How many typically a census do they have as those different bed types, those different 7 bed types, and just walk through a little bit, give you kind of an idea of what it would look like on game day. And then you could even play with some numbers, and you can see how this would populate or change as you go forward. And then, so that's the after action review tab. Any questions here on the after action review tab? Yes, sir.
Just earlier, when you talked about confirming that the hospital can take your patient, I either read or maybe it was on one of the webinars, but they want a phone call or an email to
Yeah, however you would make that confirmation happen within your healthcare coalition here. If it's a phone call, yes, we can take X number of these kind of patients, or if it's an email, if it's some other system that you use, so I'm not real prescriptive on how you go about doing it, just that you're able to.
But it's not just self-contained in the evacuating hospital, but that you have to work with the rest of the coalition.
Have to work with the rest of the coalition, yeah.
I've got a question on the transport car.
Yes, sir.
It sounds like the hospitals, in this tool, it sounds like the hospitals are trying to find their transportation. And that doesn't, I guess my question would be, can you kind of give some examples of how they're doing this, other folks are doing this? Because it seems like, looking at the transport discussion, Mark, you've got each facility is finding their transportation, their own.
How would it work I'm sorry, sir, what county are you with?
We're Stanislaus.
Stanislaus. How would it work today in Stanislaus if that were to happen?
Well, so the hospitals have, so for instance, Memorial has a regional transportation center. That might be one way. We have our EMS agency so we've got EM systems, our EMS agency probably trying to coordinate. We've got a disaster control facility. So in my head, I'm trying to figure out, okay, I don't think the hospitals are going to really, to me it makes sense that they're finding their beds, they're finding internally that would be what they're doing. I don't think they would be looking for transportation. That's got to be off onto somebody else. So I guess that's what I'm trying to figure out in my head on our scenario.
Yeah.
Or our situation.
I was, don't interpret anything more into that than what is there. Just whatever you guys typically do. And don't adapt to meet the demands of the tool, other than the 20% and trying to collaborate and work together. And but if for example, in one of the pilot tests, they had this regional healthcare coordination center. The person in the middle, they were the county. They were the county public health office, and they were the county ESF8, and they were co-located during this with the emergency manager and the EMS agent. 2 EMS agency leads came into that room, that physical room, and that's where part of them called the receiving hospitals, and part of them worked with EMS, and they had all that information there centrally. And so they said, okay, we're going to match these guys up together, and then we're going to match these medical transportation, and they kind of worked it that way. That was just one way, and then as I mentioned earlier, some of these evacuating hospitals were like, wait, we got to do all this ourselves. How do we? So whatever your system you're going to use, if you walk out here and it happened today, use that system, use that process. Is that helpful?
Yes.
Okay.
Yes.
All right, performance measures. Again, we're tracking 8 performance measures, and these will all be automatically populated as you go through the tool, as you start putting in information about number of patients and those types of things. So we're really looking at things like percent, like number 16, and I'll go over these a little bit more. Percent of patients at the evacuating facility that are identified as being able to be discharged safely or evacuated to receiving facilities during. So these numbers here, although they're in gray, you don't type them in; they'll automatically be populated as you go through the tests and through the tools. And what I would suggest when you're done with this is you save it. Save this tool, save this Excel spreadsheet, you name it whatever you want to name it, and then you have this available at the end when you have to report on your exercise and report on your performance measures up to CDPH. Yes, ma'am.
I have another question about transport.
Sure.
So I realize that you said do what you would normally do. However, this doesn't address like staffing or equipment that you would normally have to send, potentially have to send to a patient. So is there some, or are we making an assumption that there's a plethora of staff available at the receiving facility and during transport, and the equipment is all there too?
No, don't make that assumption. If that's part of whatever your real world gap, like you're not there necessarily to 90 minutes to beat the task. That's not the goal. Is what do we really have to have happen on game day? Does this help us open our eyes, perhaps, and our thoughts in terms of where we are today? Maybe if this were to happen, there's some things maybe we need potentially to work on as a coalition, as a region, that maybe we didn't know of today. Maybe in a year from now, maybe we'll be able to have a little better idea of what would happen if that would happen on game day to move a large number of patients from one facility. Like we had some flooding scenarios in this area. I know that the floodplain called for some penetrative evacuations of some hospitals in the central part of California. That would be a scenario that potentially could happen, and how you would go about moving those. But if you need that type of information and you don't have it, make sure that's all included in your facilitate discussion, your after action reviews, those kinds of things as well.
Those are questions that are going to come up during if you just say you have to evacuate your hospital, it's situational. So does that mean that we have staff that can go with the patients? And who is accounting for those? That kind of, so it's more simplistic.
Oh, absolutely understand. There's, even the receiving hospitals would be, well, wait a minute, we surge, how do we call in staff? How does that all work?
Is it based on how many you can accept? When we do the bed staff is how many can you accept right now?
Mm-hmm.
Now, if you can add staff to that, then it's a whole other element. So,
well, again, it's a 90-minute exercise, and if again, part of your scenario would depend on how you want to play that. But we would ultimately like to see, there's no actual patient, so if the receiving facility says, hey, we can take 5 in the next 2 hours, we can take 10 in the next 5 hours, whatever, X hours, that's a reasonable answer. That's an okay answer as well.
I see, for California, and I'm hoping you will correct me if I'm wrong here. I see
It-
basically two different types of exercises that we can have. Because we can search within our own county, within our own healthcare coalitions, and not involve anybody else. Or we could not be able to do that, and we could actually try to search outside into our regions. So there would be times when it would just, if we're just searching our healthcare coalition, then it would just be our county that was involved. So public health, EMS, hospitals, all those people. Or we could choose to do one year a regional thing outside of that. That's how I see we have two choices on how we do this in our county.
Nationally, what we dislike is all the coalitions. We know that there's coalitions that you're in a coalition, you're in a city, and right across the river is another state, and you typically would transport patients back and forth. Right now, we're trying to just have coalitions exercise this collectively within them, and we fully recognize that real world it's not necessarily going to go. And we'll reevaluate where we are after the first year, because we'll look at how many. Let's say it would be a large percent, I think, of healthcare coalitions who could not find enough acute care staff beds within that healthcare coalition to find a spot for all those evacuated patients. And then that brings up, how would we, should we expand this year 2 or 3 out to more of a regional type of exercise? And really, this is the actual real world and how we're doing it. So we're asking the first year everyone will keep it within your coalition. That should come up as part of your facilitated discussion. That we can only find 10% of our beds. We know if this happens on game day, we can only find 10% of our evacuated patients within the coalition. We know if this were to happen, we immediately are looking beyond. You probably already know these answers already without having to go through this exercise. So that's something we're looking at as we move on.
Okay.
Okay?
Yeah.
Yes, ma'am?
Part of the reason we called you all here together is because we are prepared as a region to conduct these bed pools and assist with this exercise any way that we can. And that's one of the reasons why we wanted to have this workshop where we can sit down and coordinate those dates, so that way the region can assist you if you can find enough beds for your facility.
Right,
That is an option.
Right. I was just kind of laying out the options because we all had to have internal county surge numbers. And so it would make sense that we would test our own internal county surge ability before we go outside of our county to do that, so.
Yeah. And then that's part of something you can, if that's part of the scenario that you want to test, did the the RDMHS program, would they go out and they get a regional, bed availability? Is that maybe something you want to test, maybe, CDPH folks you're interested in? Maybe not, we're not asking to do that, but it doesn't mean you can't do that on yourself. Because some states don't have that ability to do that, like you guys have that capability to do that very quickly. Okay, so that concludes our hands-on demo. Anybody here feel like I just can't do that, it's too hard, everybody, hopefully you can leave here. Everybody feel like a little bit easier that you can do this? It's not that challenging? Okay, most. All right, so how much more time do you want to go? Or a couple of questions that have come up. We don't like the no notice component. It's really hard for our folks to do that. Can we do it without it? And no, we want you to have a low no notice component. Thoughts, ideas about you and your facilities about that and how maybe you want to overcome that, or any issues you think you may have to, yes sir?
It seems like all of our practice drills are like Tuesday through Thursday. It would be interesting to see if we have another a Saturday or Sunday to see.
And I know that no worker.
I've worked a lot of weekends,
Yeah.
and it's, your staffing is just, more staffing. It'd be interesting to see how it would play out on a weekend.
Yeah. We're interested to see how it plays out. If you guys were all up at one of the conferences, the CDPH MSA conference, or at the hospital conference, and your facility has to do it, and you guys are there. That would be, how do you do it without the 18 folks in the county in the room when that goes down? That's a good question. I would like to find out too. I think other people. When we did this, and I mentioned this before, is the 500-bed hospital that I observed evacuating. The chief medical officer walked in, and it was really no notice because he had no idea. They were like at 95%. He walked in and just went, "You gotta be," and I'm not using that word. And he just went to the emergency manager like, "Are you?" He just face was like, I got so many better things I could be doing than this. 2 hours later, he walked up and says, "Kevin," he goes, I thought the dumbest idea I've ever. We got so many things to do." He goes, "This is the best thing we ever did." He goes, "I had no idea that I thought we were so here, there, so many things we didn't really think about and go through." And he says, "This was really," he goes, "I've been here 30 years. This is the best thing that really moved us forward. Not just us, because I had no idea we could only get 4 patients to their local other 500-bed hospital in that day." Yes, ma'am?
I was curious if you tested this with Dublin or any of the areas that have the real world evacuations to see how they would do it differently.
We didn't do it with Joplin, but we did do it with Texas, and they had the hospital that flooded. They had the foot of rain overnight, and so what happened, it flooded their basement, and it took out electrical, internet, logistics, food, laundry. It took all that out. So they had 580 patients that they had to evacuate, and so we did it in that coalition, and they understood how they had to organize and coordinate. Even though we think of Houston's this huge city, but it's a big city. Evacuating patients from one side of the town to the other is a couple hours, because it's 45 minutes from the south side on a highway speed going to the north side. So I had no idea that their coalition was so spread out that was that's going to be a challenge, because they can't do it quickly because they have a lot of assets, but everybody's spread out. Well, the performance measures, we're talking, we have 2 that deal with participation. I just want to go over those real quick. 2 that are going to test your healthcare coalition. And one thing we're going to do is we're going to percent of core members who participate in phase 1 of the CST. meaning your EMS agency, because we now require, if you're a healthcare coalition, you have to have 4 core members. You have to have 2 acute care hospitals, you have to have a public health agency, you have to have emergency management, and you have to have an EMS as part of your healthcare coalition. So we're measuring their participation in this exercise as well as core healthcare coalition member executive participation in the after action review. So above and beyond the after action review, there's your typical 8-SEEP after action report. We're asking for this exercise as well. And so, let's see. The other exercises, the other ones are, there's 2 for the evacuating hospital that we're looking at. Percent of patients from evacuating hospitals identified as either discharged home or needing to evacuate to a receiving facility. And then time to report that number. We have 2 performance measures on receiving hospitals. So percent of evacuating patients with appropriate bed identified at a receiving hospital or a healthcare facility, and then time, how long that takes to report those numbers. Then we have 2 more on transportation, percent of evacuation patients with acceptable transport to another facility that have an appropriate mode of transportation identified, and then time to identify appropriate mode of transportation for the last evacuating patient. So those are the 8 performance measures that we're going to be tracking as part of the Healthcare Coalition Surge Test. Well, if you have any more questions, or you're not sure, or you thought of something, and but I want to make sure that you guys realize that I'm very interested in how it goes here in your region and how you guys do. I'd love to come out and observe some of your exercises if you have them. I'd love to. I'll talk to Shelly and see if she has get some schedule of when those will be, and see if I could come out and see what we can do to, if you have ideas, hey, the tool, this would make the tool work much better. We're always open for ideas. We hope to do this for the next few years, and we're going to actually reevaluate this on an annual basis and kind of see where we are. But that's it. Is that it? No more questions? You guys do phenomenal work. You guys have a lot of risks. I live here. I'm a resident. I live in Brentwood in Contra Costa County, and just to know that we have an emergency system, and health and medical people are incredibly dedicated in this state. It's a privilege and always an honor to talk to you guys. So if I'll be around. If you have anything else, let me know. And thank you for this. I appreciate you guys letting me walk through this with you. That's all I have.